In this video, we have a 43-year-old female with gross tearing look, caruncular or lid edema and goiter. On further examination, we see prominent arterial pulsation suggestive of hyperdynamic state. These features are suggestive of thyrotoxicosis or Graves' disease and thyroid-associated ophthalmopathy or Graves' ophthalmopathy. Hyperthyroidism is the most common cause of hyperdynamic circulation. In this state, the thyroid hormone induces vasodilation of circulatory beds that supply muscles and skin. This circulatory vasodilation causes decreased peripheral resistance, leading to accelerated heart rate and increased stroke volume. Thyroid hormone also increases cardiac contractility. These effects are due to direct action of thyroid hormone. Thyroid-associated ophthalmopathy or Graves' ophthalmopathy is a self-limiting autoimmune process associated with this thyroid state. It is an autoimmune process associated with deposition of glycosaminoglycans, leading to swelling due to its hydrophilic properties. Pathogenesis was first summarized by Lehmann. In this, autoantibodies bind and activate orbital fibroblasts. These activated fibroblasts release chemokines which recruit T lymphocytes into the orbit. These T lymphocytes further activate fibroblasts and stimulate release of chemokines and further activation of T lymphocytes. This leads to deposition of extracellular protein, matrix and adipogenesis, ultimately leading to orbital edema. Smoking can worsen the Graves' ophthalmopathy. 20 to 60% of patients have a positive family history. HLA, B8 and DR3 are more susceptible for thyroid ophthalmopathy or Graves' ophthalmopathy. Clinically, 90 to 98% of patients present with lid retraction, also called as Koch's sign, and lateral flare of contour of retracted eyelid. Mechanism of lid retraction: increased sympathetic stimulation of Muller's sign, contraction of levator muscles, scarring between the lacrimal gland fascia and levators.
Severity of Graves' ophthalmopathy can be judged with no specs grading. Initially, the patient may have no signs and symptoms. Further, patient may develop soft tissue involvement, proptosis, extraocular muscle involvement, corneal involvement, and sight loss due to optic nerve compression. The second score for grading Graves' ophthalmopathy is clinical activity score. It includes spontaneous orbital pain, gaze-evoked orbital pain, lid edema, lid erythema, conjunctival congestion more than one quadrant, chemosis, caruncular edema. A clinical activity score of more than 3 out of 7 is suggestive of Graves' ophthalmopathy. Treatment of Graves' ophthalmopathy includes restoration of euthyroidism. Further, based on clinical activity score, patient can be managed with local measures or observation. If the clinical activity score is less than 3, patient may be started on intravenous steroids, radiation or immunosuppressants if clinical activity score is more than or equal to 4. When the disease remains inactive, that is stable for 6 months to 1 year, patient can be considered for orbital decompression, strabismus surgery, eyelid surgery or blepharoplasty.